To thank you all for joining me uh, this morning, and I'm going to talk about learning how to drop our tools. Okay, my disclosures are here. I do a lot of things involving patient safety, none of which are going to conflict with what we're going to talk about this morning. My objectives are here. We're going to describe the notion of dropping one's tools, explain the challenges with the concepts of human error and never events, and then we're going to look at deficit-based approaches to safety and compare them with some of the newer approaches. Back in the day when we used to give grand rounds, we all were at the Magnolia campus, so we could have a room and we could see each other and interact. And now I'm kind of talking into a screen. We're covering 3 different campuses. Some of you are driving in. Others are setting up your anesthetizing locations. So rather than kind of show you things that are data heavy with charts and graphs and things like that, I'd prefer to kind of focus on telling you a story that you can listen to as you're doing these other things and getting settled in this morning. So let's start. This is a picture of me, Big Dork, and standing right next to Don Berwick, who's president and founder, one of the founders of the Institute for Healthcare Improvement. This picture was probably 12 or 13 years old. It's from the very first IHI conference that I ever went to, and these conferences have 3 to 4 or 5,000 people from all across the globe that attend. There's so much going on. It's kind of hard to pick out what all the things that you want to do. But one thing that everyone told me about who went to this conference, they're like, make sure you stick around for the last lecture. And Don Berwick is actually the one who gives the last lecture of the last day, the closing lecture. This was in Orlando, so it wasn't that far away. So I figured, okay, I'll stick around for the last lecture. I can still make it home in time to be with my family for dinner. And if you've been to a conference, you know the last day is it's kind of dead. And the last lecture of the last day is even more so. There's hardly anyone there. This was the exact opposite. When I went into the lecture hall to hear him speak, it was packed. And it wasn't packed in the back, which a lot of times lecture halls are. People always sit in the back. Everyone was crammed toward the front of it. And pretty soon the whole hall filled to hear him speak. And after I heard him speak, I realized why that's so. He's a phenomenal speaker. He has a way of weaving storytelling in things that have nothing really to do with medicine, healthcare quality and safety, and kind of turning it into kind of a focus on and the things that we can learn from these other fields. If there is one person who I could speak just like, it would be him, hands down. Interestingly enough, he does have a tie to Moffitt. His college roommate was one of the former neurosurgeons here. So he was kind of interesting. When I met him, we were talking about Moffitt for a little bit. But his speeches they're just phenomenal. I can't really say enough about them. I've listened to every single one on every single conference that I've been to since. They were made into a book, and this is actually one of his first books. You can see here his collected speeches from 1992 to 2002. He has a book actually after this of the speeches since 2002, and people buy him because, again, his storytelling is truly remarkable. And what we're going to talk about today is we're going to talk about the title of this book, Escape Fire, because this comes from one of his talks. Unfortunately, I didn't see the talk live, but I did read about it in the book and then kind of got interested in it and then started reading more about this. And in order to do that, we're going to go back to 1949 and the Man Gulch fire that took place in 1949. Man Gulch is a forest 20 miles north of Helena, Montana. And this resulted in the deaths of 13 men, 12 smoke jumpers, and 1 fire guard. And smoke jumpers at the time was a relatively new field. What these were people who would firefighters who would parachute into a wildfire and begin to attack the wildfire while ground crews would take a day, sometimes 2 days, sometimes even longer to maneuver their way through the forest to the fire. It was based off of a military kind of platform for it. And you can see these are all men who are in their 20s. And, as my son gets older and gets closer to 20 and I get much, much further away than 20, they look like boys. And just imagine these people jumping out of a plane into a forest to fight fires with just the equipment that they're able to jump with. This tragically was the first fire in which smoke jumpers had died. and it really kind of fell into obscurity. This is 1949, so it's before social media, cable, things like that, where most stories are kind of passed along in newspapers, and there wasn't much record of it. But what kind of brought it back into a little bit of popularity was this book written by Norman Maclean called Young Men and Fire. You can see this is the 25th edition, so it's been around for quite a while. Norman Maclean was probably better known for his other book that he wrote, because he also wrote A River Runs Through It. If you haven't read the book, you may have seen the film, or if not heard it, seen the film, you've at least heard of it. And this was kind of picked up by many other people who became kind of intrigued with the Man Gulch fire. And just to kind of tell this story a little bit and kind of get into it, the fire at Man Gulch was started by lightning strike, and it was spotted the next day by plane. They deployed 15 smoke jumpers who parachuted in. They all landed safely. However, their radio didn't and crashed into the ground, and it was of no use to them. When they saw the fire from where they landed, which is somewhere up around here, they thought that this would be a 10 o'clock fire, which means a fire that would be out by 10 o'clock the next morning. They'd rendezvous with the ground crews and they'd be out. They were very wrong, however. The south side of the gulch, and some of it had to do with the layout of Man Gulch, the south side of the gulch right here was very different from the north side. The south side was covered in fir and pine, a typical forest that these firefighters were used to fighting fires in. However, the north side was grass. And this was something very different from what the smoke jumpers had experienced before. They really had no experience fighting fires in grass, which is important for how this story tragically unfolds. The foreman, Wagner Dodge, he spotted something concerning. He spotted that the fire was jumping from the south side to the north side, and this was speeding up its spread. The north side not only was covered in this bunch grass, which I have a picture of right here, but it also had a 76-degree, in some areas, incline. So the smoke jumpers were beginning to retreat. They're carrying their gear, which is very heavy, up this steep incline, again, 76 degrees at some points, in an air temperature of 100 degrees. Now, that's just the air temperature minus the fire that's raging, that's closing in on them. So it was really, really, really hot and miserable. And within 10 minutes, the speed of this fire progressing through this grass had increased more than fivefold, from 120 feet per minute to over 600 feet per minute. Wag Dodge, their foreman, he ordered his crew to drop their tools right around here. And he did something remarkable at the time. He took matches from his pocket and set fire to the grass in front of him. The fire quickly spread and burnt out the grass, and he laid down in this freshly burnt area of grass. And he urged his crew to join him. This was something unknown or unseen at the time, which has since become a technique that is taught, the creation of an escape fire. Because when you burn the grass in front of you, the raging fire that is behind you is not going to come and reburn the grass that's already been burnt. There's no fuel there. It will burn around it. So he escaped unharmed relatively in this area of burnt out grass, of which he was stuck in by himself because no one joined him. There were two other firefighters that were able to make it into this crevice. Let's see if I can. This crevice right around here. Tragically, however, 13 men perished. Now, this story was kind of intriguing at the time, and it was even more intriguing to Carl Weick. And Carl Weick has written some books on the psychology of organizations and teams. He's perhaps best known for the book All the Way on the Right, Managing the Unexpected, which talks about what high reliability organizations are. This is something that you'll hear a lot in quality and safety in healthcare, because we strive to be a high reliability organization. And this is actually pretty much, it's a relatively short book, but it is kind of the Bible in explaining how high reliability organizations function and things that we should emulate. But it kind of started with talking about the Man Gulch fire. And what he did is, I want to talk not so much about the escape fire, which he's written books or written papers on, but one thing in particular that he wrote a paper on, which is dropping your tools. So he goes on in this paper on dropping your tools to say that not only did these firefighters not drop their tools, and had they dropped their tools, and they know this from studies now, they would have increased their speed through the forest, running away from this fire by 20 to 30%, which probably would have allowed at least some, if not all of them, to escape unharmed if they had just dropped their tools and ran instead of carrying it. He talks in his paper about failure to drop your tools occurs in other situations too. Sailors sometimes refuse orders to remove their heavy steel-toed shoes when they're abandoning ship, which causes some of them to drown and others to punch holes in the life rafts that they're trying to board. Fighter pilots, despite being in an irrecoverable situation, sometimes refuse to eject from their plane and end up tragically dying as their plane crashes when they had the opportunity to drop their tools to get out of the plane. And dropping one's tools, if you haven't figured out now, is more than just the physical act of doing it. It's a metaphor, a proxy for unlearning, for adaptation, for flexibility. Carl Weick says, in short, for many of the dramas that engage organizational scholars, it's the very unwillingness of people to drop their tools that turns some of these dramas into tragedies, and certainly did in Man Gulch. And we're going to talk more about that. Now, Diane Vaughn wrote a book called The Challenger Launch Decision. She did a lot of her research into Challenger and some of the problems that led up to, unfortunately, the Challenger shuttle launch disaster. She coined the term normalization of deviance, which is where you may have heard her before, but she talks about this with rules. And I've spoken about rules before. If you've ever attended, rules are necessary, but they're insufficient. If you look at the number of rules that we have here at Moffitt, we have plus or minus 700 policies. And we need them, right? We need them to establish norms and things like that. But I guarantee you that we're violating these policies probably left and right, because with 700 of them, I assure you that I don't know all of them. I don't know if there's anyone who knows all of them or all the things that are said in there. What Diane Vaughn says is that organizations need to understand why rules are violated. It may be complex, it may be recent, people are unaware of it, it may be vague, they may not understand how it applies to them. But what is the challenging administrative problem that we need to address, you can see at the very end here, Challenger, is how to instill, a rule-following mentality to ensure that we have coordination control when chaos arrives, but also at the same time teach people when to drop their tools, to recognize when the rules don't apply, when we're in a situation that perhaps the people who designed the rule did never or could never have anticipated. So when the rules don't apply. So let's talk about dropping tools in anesthesia, because I think there's a pretty good example for the practice that we all do. And it kind of circulates around and centers on airway management when we look at this. And we see this sometimes with the students and sometimes not with students. And this has been seen, with all anesthesia professionals, whether you're talking about CAAs, CRNAs, anesthesiologists, kind of this reluctance, the repeated attempts at LMA placement before dropping and proceeding with intubation. So we'll try and place an LMA, it doesn't seat right, we'll try again, then maybe we'll try a different size. Sometimes we'll want to revert back to the original LMA that we couldn't seem to convince now that we've tried all these things that maybe this one time it'll work. And we know there's solid literature out there. In fact, there's a lot of it that says the more times that we instrument a patient's airway, the worse the outcome for the patient. In fact, there's not a single study that shows otherwise. It says that it's a good idea to keep doing it. And in fact, kind of the threshold, depending on which paper you read, is somewhere between more than 2 attempts and more than 3 attempts. So really, this is something that we need to get on the first, at the very least, at the first 3 attempts before kind of proceeding. When we look at other things, the repeated attempts at intubation before dropping the laryngoscope. This is from the ASA closed claim study. Anesthesiologists appeared reluctant to move down the difficult airway algorithm to the placement of a surgical airway. And this a more damning statement from the British Journal of Anesthesia, in a paper that is more than a decade old. There's a natural reluctance to perform such techniques, but evidence is clear when an emergency surgical airway is required, it is not the procedure that kills the patients, but delaying or not doing it that causes harm. So this is just it. It's not the crike that kills the patient. It's delaying doing the crike or not doing it altogether. And, tragically over, the past 20 or so years since I've started doing anesthesia, we sometimes will do a surgical airway on someone who has been unfortunately long since expired. Once they lose their pulse and they've been pulseless for a while doing a surgical airway, you're very, very late in it. A very important case, is the Elaine Bromley case. Her husband was an airline pilot who did a lot of human factors work for the airline that he worked for. Tragically, his wife was healthy and coming in for sinus surgery. They got into a cannot intubate, cannot ventilate situation. Here, the standard procedure is a trach, cric, followed by admission to the ICU. Yet both the surgical and anesthetic teams managing the patient did not execute this option. This was despite the fact that the nursing staff called the ICU, they got an ICU bed, and they brought the trach tray into the operating room and set it in front of the doctors. It's kind of this, when we get into these problems, we get the tunnel vision, tunnel hearing, we lose track of time, we don't realize how long has passed. You can see, and you'll get copies of slides, you can click on the paper. The top link there is the paper that her husband wrote, and the second one is a narrative video. So not only is this kind of a case study for human factors, but a case study specifically in anesthesia that's relevant to us. I remember years ago working with a colleague on an airway case that went to court, where it was an emergency medicine physician, took 17 attempts to secure the airway. During deposition, she imagined that it took her 3 or 4. The nurses who were paying closer attention, and clearly because they're not involved in it, they're kind of a step away, they documented 17 attempts. So this is why, really, when we talk about airways, and whenever I do airways in the ICU, I'd go up to the floor, especially bring somebody with you who keeps track of the time, because it's all too easy to say, let me take one more look. I'm almost there. And you don't realize that the patient has not been breathing for this long period of time. You don't realize that you've been instrumenting the airway over and over and over again and haven't been progressing. So this is kind of the drop your tool moment for us in the anesthetic practice. If we look, and this goes back to Carl Weick's paper, it's not surprising that dropping one's tools creates an existential crisis. Without my tools, who am I? So firefighters are firefighters by virtue of their firefighting tools. If they drop their tools and run from the fire, they're not firemen anymore, right? They're victims. They're people escaping a fire. So we build a lot of our identity and combine our identity with what our tools are and what we do. And when you think about it in anesthesia, the tool that is probably most associated with us is, in fact, it's the laryngoscope, right? This is what we do. This is our tool more than anything else. There are not lapel pins of a Mapleson D circuit or an anesthesia machine. This is the tool that we use most commonly. And when we can't get an airway with this tool, or perhaps now it would be a video laryngoscope, we don't want to believe that we can't do it. And we perseverate. And perseveration is the common thread behind so many different disasters in so many different fields over so many different years. So what I'm going to do is I'm going to talk to you about in the next half, or the last half of my presentation today, is talking about how we drop tools in patient safety, because we need to do the same thing. We can't keep doing the same thing that we've always done and expect that we're going to incrementally get safer. We need to kind of change what we do. And there are a lot of tools in patient safety, like the laryngoscope, that we kind of identify with, that we carry with us, that it's probably past due time that we drop. And one of them is talking about the concept of error and mistakes. Error, mistakes, accidents, we kind of join these terms, although they mean slightly different things, but we'll focus on error. And I'm going to take you back a little bit further. This is the journal of Charles Lindbergh from 1938. The readiness to blame a dead pilot for an accident is nauseating, but it's been the tendency ever since I can remember. What pilot has not been in positions where he's in danger and where perfect judgment would have advised against going? But when a man is caught in a position, he's judged only by his error, seldom given credit for all the times he's extricated himself from even worse situations. Worse than that is the blame heaped upon him by other pilots, all of which have been caught in parallel situations themselves, but they haven't been kind of punished by them. So there are a couple of things here. We talk about blaming people after accidents and kind of this concept of pure blame, or being blamed by other pilots. And it's kind of, it's important. And again, also, when you think about that, this is approaching 100 years old, that what he's written, this has been going on for a long time. Blame has been going on forever. We're never going to get away from it. And Brene Brown has done a whole series on blame and what it means and why people blame and things like that. You can find the videos online, or I can help you find the link. But this concept of this lateral blame or lateral violence by people in healthcare, because blame is included in some of the definitions of lateral violence. When one of your coworkers makes a mistake, you want to kind of blame them for it. What's kind of interesting, and I've talked about this before, the number one question after we describe a case anywhere, the very first question that people get asked is, who did it? And there's a reason behind that. And some of it's because we want to make ourselves feel better, because we engage in this process that Cook and Woods called distancing through differencing. We find out who made the mistake, and oh, Jonathan made the mistake. Why did he make that mistake? He's not as vigilant as I am. He's not as smart. He trained at a state school. He's been out of the game too long. He's not in the OR nearly as much as I am. That's why he made the mistake, and I'm not going to. And that's a very dangerous position to have, because when you take that, you find that there are no lessons for you to learn of the mistake. You blame it, again, the mistake on the person, instead of seeing this as, this happened to one of us, it could happen to any of us or all of us. We separate ourselves. And this is, again, kind of this concept of, the blame being heaped upon our coworkers, the side glances, the lack of trust that we have. We don't want that person relieving us or taking over our case from us, or even helping us out, because we feel that they're going to make an error again. So the problem specifically, taking this back to medical error, is, and perhaps the biggest problem, not just with medical error, but error in general, is what is it? It could be an act of commission, or, doing something or forgetting to do something. It could be latent or active. Active is at the sharp end. So a nurse programs a pump wrong. Well, why did the nurse program the pump wrong? He's been doing a bunch of overtime. Why is he doing overtime? Because we're short-staffed. Why are we short-staffed? Because the hospital across the street is paying so much more, and that's attracting all of the nurses over there. Are you ever going to end up at this deep-rooted situation where your pay is not competitive, or are you just going to blame the nurse for programming the pump wrong? Certainly one of them is the easier explanation, and the thing that's easier to manage. So we need to be, though, careful about balancing these things. Are we looking at events at the active side, which is closest to the patient, the sharp end, so to speak, or the latent, something that is at the dull end or deep within the organization? Is the error, is it a slip, a lapse, or mistake? We can use error to describe a cause, a process, or an outcome. We can talk about how it's shaped by perspective, the person making the error, so to speak, or someone who's looking at it from the outside, because from the outside, you're not seeing what the person who's actually involved in the event is. And we'll talk about this more in another slide, including outcome and hindsight bias. Now, specifically in anesthesia, and this comes from Ken Catchwell's paper. If you remember, he was one of our visiting professors 2 years ago in the medication error category, which encompasses the greatest number of terms, had widely variant definitions, which represent fundamentally different concepts. So error is not the same thing. It means different things to different people. And this becomes a problem because we have no idea if error rates are going up or down. It depends on how you define it or how to compare it amongst different departments, divisions, units, even within the same hospital, because error can mean so many different things. Now, when we look for bias and error determination, and this is a quote that I like, it goes back to Homer, even a fool may be wise after the event. This is what got me into patient safety, because by virtue of the fact that I'm receiving an email, safety report, call, something like that, I already know the outcome. The outcome's already known, and it becomes very easy to trace this outcome back, and I can figure out what caused it. The problem is that I'm starting at the end, and what's visible to me is not necessarily visible to the people who are involved in the event at the time. And we have to be mindful of that. Otherwise, we're not going to solve any of these things. Henriksen and Kaplan call this being smart after the event. We're all smart after the event. There's, in fact, outcome bias, where the evaluation is biased significantly given the outcome. And the problem is that the outcome is not always known. It can't always be predicted. We can predict and we can kind of steer people's choices in the matter. Right? We can tell people, we can help people make better decisions, better choices, but we can't change the outcome. You could give an antibiotic that a patient's allergic to, and they may have like a little rash, they may have nothing, but they may have full-blown anaphylaxis and tragically die. When you give the wrong antibiotic, you can't control that outcome, but you can control, again, the choice or the decision that was made. Hindsight bias is that once an outcome is known, people alter their perceptions of how likely it was to occur, right? When something horrible occurs, we're like, oh yeah, I could easily see that coming. And again, only because you know the outcome, it becomes easy to see the path through it. Interesting enough, the study that came out and is still published or online ahead of publication is that expertise in patient safety may reduce but does not eliminate these biases. And this kind of parallels what Daniel Kahneman said in Thinking Fast and Slow. When he got all the way to the end, he admitted, he's like, listen, I'm better at spotting the decision-making mistakes that other people are engaged in rather than my own. And that's after a lifetime of studying this, winning a Nobel Prize. It's easier to see the mistakes that other people are making than our own. In fact, the easiest person to fool is, in fact, ourselves. Now, when we dig a little bit deeper into the problem with event reviews, and this is from Heraclitus, no man ever steps in the same river twice, for it's not the same river and he's not the same man. And this kind of goes along with the concept of what a complex adaptive system is, which is what we work with in healthcare. We're not building widgets on a factory line where A leads to B and B leads to C and C leads to D. And if D doesn't turn out the way we want, we can just kind of follow it back in this straight line, because it matters when you look at the system. It matters the time, it matters the people, the patients. There's so many different variables in there that this just doesn't work in this linear fashion. Observing a system after an adverse event is not the same system that produced the event. And this is typically what happens. After something bad happens, we go and take a spend a lot of time putting scrutiny on the system that occurred, and we look at it very closely, and it's changed either due to the natural complexity. Again, we're now looking at it involving different systems, different people, different time of day, different operating rooms, so many different things. The passage of time changes these complex systems, and even the event itself after something bad happens. And this goes back to the work of Nancy Levinson, who looked at NASA, that there's a lot of vigilance, right? After Apollo fire, after Challenger, after Columbia, we spent a lot of time focused on safety. And then after time passes and we get further and further from the event, all of a sudden, there's this decrement of vigilance and atrophy of vigilance, and we sink back to where we started from. So we need to pay close attention to that. Recall of events fades quickly after 1 week. This was specifically done in the operating room. Members of surgical teams were universally inaccurate in their recollection of major details from the operating room. And this asked them their recall versus what was videotaped. So when they saw what was there, they asked people what happened. Universally inaccurate after 1 week. In fact, there are many times it's inaccurate immediately after, but certainly the longer that we go from the event, the less likely people's recall matches up to anything that happened there. Elizabeth Loftus, really interesting. She's a psychologist. She's written several books on this. This one called Witness for the Defense. She talks just about how unreliable eyewitness testimony is after events from pretty much from the very beginning. We can't really rely on that because people will see kind of what they want to see. And kind of the best example, and I know I've given this before, is inattentional blindness. This is the invisible gorilla. And what you can see right here is the question is, you watch this video and there are 3 people with white shirts, 3 people with black shirts. The people wearing these white shirts are told to pass the ball to each other. And the instruction for someone watching the video is count how many times someone with a white shirt passes the ball to somebody else with a white shirt. And in the middle, a woman who's dressed in a gorilla suit marches her way to the center of the video, pounds on her chest, and marches out the side. And it turns out universally over now more than a decade, half the people who watch the video don't see that. Many of them don't believe that this ever happened. They think that the video that they watched again after they were told that there was a gorilla was changed from what they originally saw. They just don't want to believe that they missed it. You can go to their website. I think it's invisiblegorilla.com or something like that. If you Google it, you'll find it. There's so many examples of this that they do. One of the really neat ones that I liked, and the YouTube video for here is on the bottom, is you have an actor who's approaches a stranger on the street and is asking them for directions. They're asking them for directions. And what they do is they then have these movers walk with a big wooden panel right between them. And when that happens, the person who's talking, the actor who's talking to the stranger on the street, swaps out with the other person who's carrying the board. And now all of a sudden, it is a new person, this new person talking to the person on the street asking for directions. And again, 50% of the strangers on the street have no idea that they're talking to someone completely new. And it does make sense because you're focused on providing this person instructions, right? You're focused on the directions. You don't sometimes even get a good look at the other person who you're talking to. Now, with that being said, half the time they do recognize it, and those videos are kind of funny too, because the person on the street, either gets mad or gets angry or starts laughing, all sorts of reactions. But it's incredible to think that half the time we're talking to someone, we may not even be focusing on what they look at, and we can swap them out and carry on the conversation. So when we talk about human error, and this comes from the work of Cook and Nemeth, basically he's saying that high rates of human error point to a particular form of a problem, not by the people who are involved in the incident, but rather error by those who assess the accident source and evolution. So in other words, if you're working with a team that is finding huge amounts of human error, he says it kind of gently here, more forcefully in some other talks, but essentially you're working with kind of amateurs. Marino, who worked in aviation safety, said for a long time, the discovery of human error needs to be considered a starting point in the investigation, not an ending point. So why did the humans make the error? It's very easy to say there's a cause of human error. We can punish the person, we can shame them, we can retrain them, coach them, all sorts of things, but it doesn't help. It doesn't prevent them from making the error, and it doesn't help someone else from making the error. Essentially, human error is like a fever. It's a symptom of an illness rather than the cause. It's a marker announcing that there's a problem in the architecture of the system that you have. And finally, Trevor Kletz, who's one of my favorite, who's got a lot of lines like this. For a long time, people were saying that most accidents are due to human error, and it's true. In a sense, it's not very helpful. It's saying that falls are due to gravity. And basically just summarizes this very well right here. We're looking at, humans make errors. As long as we have humans in systems, they're going to continue to make errors. Stopping at human error does not help us solve what the problem is. Now, once we kind of discard or drop the tool of human error, if we could wipe this term out completely and just go for the causes of the human error, I think we'd be much better off. We can also see that some other tools can begin to fall away, and one of them is never events. You can see right here, this is the most recent list of never events from the National Quality Forum. You can see a long list of events here. The ones that are probably most pertinent to us are in the top left. It's surgery in wrong site, wrong patient, wrong procedure performed on a patient, unintended retention of foreign body, and intraoperative or immediately postoperative post-procedure death in an ASA class 1 patient. This term, never events, was introduced in 2001 by the CEO of the National Quality Forum at the time, Ken Kaiser. He said that these are events that are unambiguous, they're serious, and they're usually preventable. And that's what gets kind of a little interesting when you say usually preventable. How can something never occur if it's only usually preventable? If you want something to never occur, it should be always preventable, right? And it turns out, based on this paper right here, you can look at common characteristics of never events, because now several other organizations, including insurers, you can see Cigna here on the bottom, they talk about never events. And what this article did is said, what is a never event? They started with something very broad and vague like that. It turns out that preventability, depending on which definition you use, you can see Leapfrog is the only one that says always preventable. Other ones say largely preventable, usually preventable, or just kind of preventable in general. They all have differences in harm or severity and accountability. So this is kind of a term that, again, like human error, we throw this out, but it means different things to different people. And when you start having different things to different people, how can you use this as a target? So the problem with never events is that in more than 20 years, there's in fact no universal definition of never events. So how preventable are they? Well, this again, if you're saying something is usually preventable, then they're not always preventable. Then they're going to occur, and never is not really the answer here. The point in using never events is that it triggers this kind of emotional charge. When you're saying that something that should never happens, people are angry. People are motivated to do something about it. And that's kind of what the goal was in calling this a never event, but it doesn't help you prevent it. Never is in fact a normative preference, not an empirical frequency. So the goal is that this should be your target, that these things should never occur. It shouldn't be your target that they will never occur. And just kind of as an example for that, look at wrong side surgery. In 2018 to 2021, wrong side surgery is 8% of the sentinel events that are voluntarily reported to the Joint Commission. It's estimated to be anywhere, depending on what population you look at, 0.09 to 4.5 per 10,000 operations in the United States. And in 2023, reported wrong to the Joint Commission, reported wrong site, wrong procedure, wrong patient, wrong implant surgeries increased 23%. 23%. So this is far from a never event. And the problem with when you make never a regulatory target, then it kind of becomes the name, blame, and shame. You look for somebody who's responsible for this never event occurring. It leads to reporting, suboptimal investigations and understanding of events. You begin to argue, well, was this really a never event? How can we kind of change how it gets reported? We'll talk more about that in just a second. So avoiding a never event is also, again, not a daily target. None of us come to work with the thought that, hey, today I'm not going to commit a never event. That is not Moffitt's daily goal. It's not to have a never event today. This is something that's done in aggregate. This is kind of a deficit-based thing. We want to avoid bad things, but what we do far more commonly, and I'll get to this again in just a little bit, is we focus on, or what we need to focus on is what we do want to achieve every day, not what we don't want to achieve. We look at zero harm because that kind of ties in very well to never events, because we do this too. Just like never events, it's an aspirational rather than achievable. We're never going to get to zero harm. Exactly. And what we need to do is shift our focus away from this ultra safe thing, which may happen when we're doing simple operations on healthy ASA1 patients, to active risk management, which kind of puts us over here. You can see scheduled surgeries here, trauma surgery is here. Cases that are high risk cases are here. When we're kind of shifting, this is something that we do very infrequently. We need to kind of take this mindset of here, how can we actively manage risk rather than avoid all things that could possibly cause harm? And you can see kind of this mirrors what's right down here, which is a professional phishing. And this comes from M. Alberti's work. And kind of the most frequent recurring requests of expert fishers are not for more regulations, but the opposite. So they don't want more rules. What they want is they want more tools so that they can manage the risk that they're faced with. They know that their job is risky. They know that there are harms that can come from it. So if you give a bunch of rules to a bunch of guys and girls who are on fishing boats that are in the middle of the ocean, you might as well throw that overboard. What they want is, these people are not suicidal. They want to make it home. Give them what they need. They want GPS equipment. They want all these electronic devices so that they can mitigate their risk rather than a bunch of rules and policies and procedures and things like that. Now, with zero harm, the things to keep in mind is that some harm is simply not preventable. For example, the first time a patient has a medication that they've never been exposed to before, they have an allergic reaction. You have undisclosed medical history, patient who comes to the operating room, they're adopted, they don't know their family medical history, and they have a malignant hyperthermia. Surgery itself is not zero harm. Surgery itself is a harmful event. There are lots of complications that can occur. You're inflicting damage to tissue. The goal is, however, that you're increasing the harm now. You're increasing the risk temporarily so that long-term you get the benefit and you get decreased risk by having this operation. At least hopefully that's what it is. There are no universal indications to eliminate all preventable harm. The best practices are still not 100% effective. So a lot of times we'll look at things like CLABSI, right? Or CLABSI or CAUTIs, we want to decrease these to zero, and then we get bummed out. Oh my God, we had one last month after having 5 months without it. To me, that's good. In fact, that's better than continuing to have zero, because you will never, ever get zero. If you've gone years without it, you're probably not counting it correctly. I remember looking at an institution, they had zero ventilator-associated pneumonias what they did is they just called them all tracheobronchitis. It's a way of gambling and gaming the numbers to achieve this target that is not really ever achievable. So again, nothing is 100%. If you're at 100%, you're probably fudging the numbers in some way or another. We want low rates, but we'll never get to zero. As long as there's innovation, there are going to be new unimagined sources of harm. So Paul Virilio, who's a French philosopher, said that when you invent the ship, you invent the shipwreck. As long as we're inventing new ways of doing things, we're also inventing new ways of these things not going well. And that there are some harms to focusing on zero harm. First is it's demoralizing to strive for the impossible goal. We get bummed out when we're the person or our unit has the one case of something that should not happen. It becomes immeasurable when you're measuring zero again. And if you tie incentives to it, there's incentive again to hide, to argue about preventability. We look for ways, how can we exclude this case from our account and other unprofessional behavior? The VA system, you may remember a couple years ago, was charged with getting all of their patients in, their new appointments in within 14 days. Well, on paper, they were all in within 14 days, but in practice, they were not. And patients continue to die while on the waiting list to see somebody. So again, it encourages gaming of the system. Our goal very clearly should be in these cases, should be learning and improving, a continual reduction, targeting zero, using this as an aspirational goal, but realizing that occasionally, one blip, two blips away from that is not the end of the world. So kind of which tools do we carry? Going back to kind of the definition, dropping one's tools is a proxy for unlearning, adaptation, flexibility. This shift from prevention to a focus on identifying and managing risk. And in the last couple minutes that I have with you, I'll give you some examples. The first one is that the DUI laws, the first one in the United States, went on the books more than 100 years ago. Still, 30,000, at least 30,000 to 100,000 people drive under the influence every single day. The war on drugs was first declared by Richard Nixon in 1971. People are still using drugs. And then To Err is Human came out in 1999, but there's still harms and harms being made to patients. And in fact, in many areas that could be preventable. So what can we do about it? Well, I think the biggest thing is we need to kind of, again, shift our focus away from this preventability and looking at how do we mitigate risk. So this is a article that I really like. And Jessie Singer, who wrote the article, she wrote a book called There Are No Accidents. And it's really good. It doesn't talk about healthcare very much at all. It's talking about kind of other things. She was inspired to write this book. One of her best friends was killed as a bicyclist, hit by a drunk driver. She began to kind of dig into this and look at this. So this talks about Utah and how they made their streets safer, reduced the amount of injuries and drunk driving accidents that they had. Well, what they did is that they didn't focus on preventing drinking. We know going all the way back to prohibition that prevention just doesn't work, right? They didn't focus on punishing those who did. That's not to say that they let people off the hook. They didn't, because these are people who still made a choice to, drink alcohol and then engage in driving, but they didn't focus on punishing. What they did is they made it safer for them. So what they did is they took public transport and they increased it from the areas that people drank to their house, realizing that you're not going to take a bus from the bars if it drops you off a mile from your house or half mile or even 3/10 of a mile from your house. You're going to need transport that puts you relatively close. So they did that. The other thing is that they increased the frequency of this transport. So if the bus just left and you're outside the bar, you're not going to wait an hour. You're not going to wait 30 minutes for the next bus. You're going to risk it and get in your car and drive home. So they increased the frequency of these bus transports. And then they made it cheaper or no cost. In fact, they made it no cost for college kids. So they didn't have to worry, can they afford, the bus? And this goes back a little bit before Uber, was certainly as popular as it is now, and you can just put everything on your credit card. But they made it safer by giving people what they needed to avoid the actions that they shouldn't be doing in the first place. So lessons here for patient safety are that we don't focus again on preventing error. We don't focus on punishment. Now, that's not to say that these aren't part of it. And in fact, when we talk about restorative practices, some sort of punishment and shame, it appears to be at least somewhat necessary on some level, not beating yourself up over things, but at least feeling this remorse for what went on is important for changing behavior. But these aren't the focuses of it. The focus is to make it safer to make errors. You design systems that aren't one step away from disaster. You avoid, trap, and mitigate things. You create barriers, recoveries, and redundancies so that bad things don't happen. And again, we can talk about the same thing. This is with driving under the influence. Talk about the same thing with substance abuse. We can lock up people who are addicted to drugs all day long. It doesn't really change their number very much. What does, interestingly enough, is needle exchange programs, because people who participate in needle exchange programs are 5 times more likely to get into recovery than those who don't. So it kind of becomes the opening of not shaming them for using drugs, making a little bit more out in the open, and then kind of gradually building their trust and working them in to programs that will work, that will get them off of these drugs. And we need to kind of take a similar approach to error. So my last slide right here before I let you guys go to the operating room. Mistakes, these are mistakes, not willful acts, but mistakes are morally neutral. We all make mistakes. This comes from Sir Liam Donaldson: to err is human, to cover up is unforgivable, to fail to learn is inexcusable. Cover up, we say, is unforgivable, but if we punish people for making mistakes, they're going to continue to cover up. So really, this is on us as a system. We need to focus not on the person versus the system, but the person in the system, and learn from things that have gone wrong, but also learn from when things go right. So when we look at what we normally do in our daily activity, we have kind of these outliers, and it's easy to study them, but you'll notice that the outliers occur much less frequently than everything that occurs. So what we need to do then is focus on the majority of the time when things do go right. And then, combine this from learning when things go wrong. We need to learn essentially from everything that we do. So that is the end of my presentation. I want to thank you guys for your attention, and have a great day and a great weekend.
Thank you, Dr. Cohen.
You're welcome.